Yes,
You
sir.
should be seeing my slides.
Yes, sir.
Yes, yes.
So firstly, let me just say that the sessions are great. I congratulate Anil, Dr. Rajshekhar, Deepak, Davidson, and Dr. Sandeep for facilitating meeting. And I'll tell you why it's important right up front. The highest, this is a paradox that we're dealing with. The highest risk cases seem to have the biggest benefit from what we do. But on the other hand, if we don't give them complete revascularization, we don't achieve the prognostic benefits, especially if we have to deal with all the prognostic significant lesions. And that's why we're talking about hemodynamic support, because it seems to be important if you want to achieve complete revascularization in these highest risk patients who would benefit the most. Now we understand that for complete revascularization, firstly, which is usually multivessel PCI, we need the skills of complex PCI, atherectomy, CTOs, calcium, small vessels, long left vein, we understand very much, and imaging and optimization. On the other hand, the hemodynamic support, just as Dr. Sarat already talked about, becomes important in assessment, in evaluation, and utilizing the right support for the right patients. I think that's the expertise in an area of hemodynamics that we all have to achieve, gain, and also understand hemodynamic support. So I wrote up this editorial along with Sanjog on CHIP fellowships and really emphasize a very important point that we need to have, sorry, let me just get this out of the way. I've got something on my, So we need to emphasize dedicated CHIP training programs, just like my colleagues Anil Kumar, Raja, and Deepak have organized. And that will improve access as well as outcomes. But more importantly, was this the next step, which we said. Sorry, are you still seeing my slides?
Yes, sir. Yes, sir.
Okay, thank you for that. My slide's moving, and that's why it's sort of. Maybe. Okay, but the overarching message is loud and clear that for most regions across the world, interventional cardiologists in training need to be defined into dedicated all-round training program aimed at providing proficiency in complex PCI in high-risk patients, including hemodynamic support. My job is to talk to you about IMPELLA, and I certainly don't want to sell IMPELLA to you, but I want you to realize that there are benefits, and we have to understand these benefits given our scenario of financial constraints, lack of reimbursement, and yet define which patients would benefit the most, and therefore help our patients to get complete revascularization, especially our surgical turndowns. We do realize that IMPELLA is one of the most physiological devices out there, and this is well understood. And it's got a lower learning curve, obviously, compared to tandem heart, which will soon be available, by the way, in this country over the next year, and ECMO, as you've just heard Dr. Gopal Murugan talk about, which is clearly essential for those in shock and those with intractable ventricular arrhythmias, or those who have failure to thrive. So the real benefit of IMPELLA lies in the scenario of, firstly, supported PCI. And the supported PCI, it is physiological. It increases flow, increases aortic pressure, increases cardiac power output, which is the new index of prognosis in most of our patients. It decreases wall tension, mechanical work of the heart, it increases coronary blood flow, and increases cardiac output and decreases oxygen demand. By the way, this is both physiological as opposed to ECMO, which is totally unphysiological and increases afterload, so on and so forth. Want to emphasize that in this scenario, whatever is available to us at the moment, the 2.5 gradually is being phased out, and soon you're not going to see it. In fact, it's even in our own country, it's getting difficult to get because ABMED is concentrating more on the CP, which is really the device to go to if you've got to support the heart adequately and also in shock situation, because the present CP can give at least 3.5 and up to a 4.3 liters of flow per minute. IMPELLA 5.0, of course, is one which is used through a surgical cut down and gives 5 liters of flow. It's a large size, 21 foot French size, and IMPELLA RP, of course, is a venous right side support, which is extremely useful for right side failing heart or in terms of using biventricular support with an IMPELLA left side. So clearly our discussions are going to hold around IMPELLA CP, I don't want to belabor the point of heart recovery. We've talked about supported PCI in high-risk patients, and that's what we're going to concentrate on. But obviously, the philosophy of heart recovery is what is taking the CP forwards, because that's what supports the heart, decreases alcohol consumption, and therefore, in a cardiogenic shock situation, we need to institute it earlier if we want to actually have patients surviving before their lactates go up and the patient is actually not in stage 3 as far as SCI classification is concerned. But on the other hand, we have to realize that we live in a system which does not pay. And in these high-risk patients who may have a 50% survival or a 40% survival, or a 60% survival, who pays becomes an important aspect. So I can't just, I think there's a bit of always a throwback around these things. The first case in Asia was done by me on 19th April 2007. And this was in an 83-year-old male who'd been diagnosed as severe triple vessel disease with a pipe and was advised bypass surgery 15 years earlier. Had an infarct, went into cardiogenic shock, and that was the first case, not just in the country, but in Asia. We airlifted him on a ventilator. Ejection fraction was 30%. He was hypertensive. Those were his global STT changes, as you can actually see. And these were his aortic pressures, 77 over 52. At that time, his PA was 44/27. So these were a bad situation for him. He was put on an IMPELLA. That's 2007, 19th April. RCA was revascularized. Left vein was revascularized. Circumflex was occluded. The guy survived. And he subsequently went home 7 days later and did extremely well. But we did 15 cases in that year. And by 2007 September, we were invited to transmit the first ever live case of IMPELLA to the main arena of the TCT as well as the coronary theater. And that was our live demonstration when actually the Protect 1 study was ongoing in 4 centers in the United States and it hadn't been approved at that time. Anyway, that's a history. At 12 o'clock night, we did two cases with ejection fraction of less than 20% with last remaining vessels and failing heart. One of those actually had a cardiac arrest 5 minutes prior to our transmission. And this was the comment of Jeff Moses at that time saying first ever cases of IMPELLA was a beautiful demonstration of the most treacherous cases that they had seen. Well, by 2008, after we'd done and presented the data on 20 cases, it was out of our hands. No more available in India because it had got provisional approval in the United States. And we had great attempts at reintroduction of this device and finally persuaded Abiomed in June 2018 to reintroduce the device. And we are happy that it's available with us. Let me take you through the learnings we've had over this vast experience of 15 years ago and then more recent, the 5-year use of IMPELLA. Of course, the hemodynamics, it supports hemodynamics extremely well. Here's an example of left main being occluded with a balloon for a stent post-dilatation in a patient with left vein bifurcation disease. And you actually see no aortic pressures at all. Aortic pressure pulsatility is gone, but then the IMPELLA supports the heart at least for a finite period of time. And over a 40-second to a minute period, it still provides adequate flow to the body. We moved on to Smart Assist, and I think I've got to emphasize the Smart Assist, which we launched in September of 2022, because this is now getting smarter. It's easier, by the way, it's easier to set up, just takes 30 seconds. It uses sensors and no more pressure transducers. It uses optical sensors to measure pressures. It enables, there's a wire port which allows you to retain the wire in case of withdrawal of the sheath or IMPELLA, and therefore enables escalation of care if needed, which meant if you wanted to go to ECMO, again, you have a wire there. If you want to de-escalate, if you wanted to put pro-close, it's still possible. And the screen, of course, gives placement signals, and these signals can be used for subsequent mal-placements or replacements in the CCU. So that's a very important aspect of this. Of course, it also gives, if you put a thermodilution catheter in, it gives cardiac power output, which is extremely important in assessment of these patients. So though perhaps not more for protected PCI, but more for cardiogenic shock, it has multiple advantages. And of course, the next gen Impella is the Impella ECP, the expandable CP, which has of course gone into its first phases already. A 9 French catheter, which is expandable, pump expands it to 18 French, designed for 3.5 liters flow per minute, for protected PCI, specifically and not for shock, can be kept in for 6 to 12 hour duration, throw away after that. It's been granted a breakthrough technology by FDA, and of course, studies have moved up ahead with the device. Having said that, I must also tell you that all companies, Abbott, Boston Scientific, are working on percutaneous mechanical circulatory device like Impella to support the heart. And in the next 2-3 years, we're going to see a variety of devices coming forth for percutaneous VAD. Let's go to our understanding of how do we understand these things. Here's a patient, 78-year-old diabetic, 25% ejection fraction, severe calcific TVD, viability in all 3 territories, and this is what he had. He's had a recent MI. He's been in pulmonary edema three times. His RC is calcified, and his left system is calcified, severe triple vessel disease, there's LAD, well, our planning was to treat RCA, and then move ahead to treat the circumflex OM, and then LAD distal, drug-eluting balloon, LAD proximal, rota, lithotripsy, stent. See how difficult the whole situation becomes, even with best of our interests in hand. This is a live case. We were distracted in multiple ways on this guy with a PA pressures of 70. By the way, I must tell you, of course, how to do single axis Impella as well. This is a live case of a single axis Impella, as you can actually see. For single axis Impella, you put a needle, and maybe I should just show you that, in the upper diaphragm, in the two. You can actually do it here or here, halfway between the central and the diaphragm, and just and put a needle here. And once you've done the needle and you've gained access, and then of course you can put a sheath in, but it's very important to understand the sheaths. We use a pinnacle destination sheath, which is very important. It's a hydrophilic coating, so has least interaction. Some other sheaths, by the way, like a cordis, will actually have such a friction that you can't put it deeply in. 6 French sheaths can go in, and by the way, it's only possible with an Impella CP, which is a 14 French sheath in the groin. Those are important aspects. Yes, please. Did I? Rajshekhar, do let me know, because I'm not timing myself. But I just showing you the technique. Can you hear the sound?
No, sir.
It's an O1. So I went in with a micro puncture needle on the outer side. I then put that needle in, and now put an 035 wire. And if you just double check it on the fluoro that it's gone up, and you take that out, and this is a 7 French pinnacle destination sheet going from Terumo. When you put that, we use a dilator first to ease open the puncture that we made. And after the dilator, and by the way, always when you do anything on a single axis, hold on to the Impella catheter. Otherwise, the Impella would just push in and even perforate the left ventricle. So it's very important to do that. And then and then that's the dilator, and then a destination sheath will go over that, and then once the destination sheath's gone in, you can actually then function through the Impella. By the way, destination sheath stays 10 centimeters out, because you just can't push it in completely. A 6F sheath can be pushed in completely. A 7 French sheath will stay partly out. So your guides can become short when you're doing this. And a 45 French sheath is better than a 65 French sheath. But here is that comes in, and look at the way I'm holding the Impella catheter. But anyway, going on to the case, I had 4 complications in this case. And this is, of course, I couldn't cross the OCT catheter, so I dilated with the non-compliant balloon. There was an indentation, so I went with an OPN and dilated it with an OPN at 35 atmospheres. I should have OCT'd at that time, but because I still had indentation, I went ahead with an IVL, and I delivered 80 pulses with an IVL, and I thought I had an adequate result. I then did an OCT run. I then implanted a stent, still had a residual stenosis, and then went ahead and did an OPN, a 3 millimeter at 40 atmospheres, got a great result and a great OCT result. But look what happened. When I went into the circumflex, lo and behold, I implanted the stent. My colleague injected air, and suddenly there was hypertension, chest pain, slow flow air embolism, which took 5 minutes to return his pressures back. But luckily, the Impella supported him adequately, though he was having chest pain. So we got over the first complication of air embolism adequately on a 25% ejection fraction. He finally recovered, so I went on to rotor the LAD, which was the plan. This was the infarct-related vessel a month ago. As I rotablated that fairly aggressively, you would see that the next thing which happened is that he develops a slow flow phenomenon completely, again with chest pain, hypertension, and closure with marked ECG changes. Well, we recover that with distal nitroprusside and flow is restored, and then I go to implant a stent. I then gave up the drug-eluting balloon on the distal vessel, go to implant a drug-eluting stent across the diagonal, and then I lose the diagonal. So he continues to have chest pain and STT changes, so then I do a tap into the diagonal, which was not my initial plan, it was provisional. Finally, having done a tap into the D2, I have a great result, and then I do a IVL to the proximal. You see that there's an eccentric lesion. This is rototripsy. You see the proximal eccentric lesion. I still have an eccentric lesion after delivering all my pulses of the 3.5 millimeter, and I therefore decide to implant the stent and then pick up quite a residual stenosis, so I go with an OPN at 40 atmospheres. My problem was that I didn't IVUS this, and at 40 atmospheres the indentation is gone, but I actually have a perforation. Yet the patient remains fine, and I was able to put a graft master into this and implant it dilate it at 22 atmospheres, and then of course do an IVUS, and had a good TIMI 3 flow result and a perfect result finally. I'm not going to take you further through number of cases that I have to actually talk to you about, but actually just to emphasize the fact that it's the learning experience around all these things and understanding, and never give up the basics around any of these aspects of how we have to do complex PCI. High pressure, ultra high pressure balloon dilatation should never be performed without imaging, without optimizing. And also always looking at the vessel lumen area, MSA rather than eccentricity. Last points, and this is just going to be my last 3 slides because I know I'm wary of the time frame. In January of 2020, we all got together for a consensus on supported PCI. We must remember that till now we have the Washington, the Seattle, Washington University scoring system to us, and scoring systems by Detroit available to us. We created ourselves what we felt was a standardized algorithm to guide us to use left ventricular assist for complex high-risk PCIs. This has now been published in Asia Intervention, as you can see, and this is our scoring system that we use in our center, and would encourage you to use that to decide. And this is, by the way, there are numerous differences here compared to the earlier scoring system from United States. We have taken age as one of the important criteria. We have actually removed hemoglobin less than 8 from our criteria, as a number of Indians have low hemoglobin. We've actually increased the syntax score from 22 to 32, as much of the Indians have complex cases anyway. And we've actually made a couple of other adjustments in this whole, and of course created the scoring system. This is more for the fact that we ourselves do not understand which are the patients we should use it in. We've decreased from 35 to 25 our scoring systems, and therefore we believe that this is a score which we should use prospectively and analyze and see how we can define and redefine the use of IMPELLA, which is a useful and yet an expensive device in our Indian scenario, and we should really start prospectively studying the use of all this. I'm actually going to go to my last slide to say that I think meetings such as CHIP that you all have created and the CHIP C2 India, which you all know is coming up, are the real fora to expand the knowledge around complex high-risk PCIs and give the best outcome for our patients. And I therefore urge all of you, I thank you all for creating this meeting. I wish I could have been there with you. I'm traveling for the India valves tonight, but I hope to see you all again at CHIP CTO India and continue the learning process that you all have created. Thank you very much for your attention.
Thank you very much, sir. It was a very informative presentation. So what about groin management following IMPELLA? Would you always try using per close device, or is there a role for manual compression following removal of the IMPELLA sheath?
I think large bore access has to become deeper. You've asked a very important question. And you know, on one hand, we know that our devices are expensive. On the other hand, 14 French should never be left to groin compressions. That's the first point. Second, all our supported PCI, we do pre-close. And learning large bore management is an important aspect of our training in CHIP PCI. We, in fact, have to all of us to do ultrasound guided punctures, make sure that groin complications, hematomas, and blood transfusion are an important predictor of worse outcomes and mortality in the long term, and we've got to avoid it. And finally, never a groin compression because these patients, you want to remove the device. And by the way, there's a de-escalation algorithm also built in our publication. But we de-escalate if hemodynamics are stable. We actually go down and remove the IMPELLA on the table. So it is much better to actually have pre-close in that situation in patients who are already anticoagulated.
Dr. Seth, amazing case that you demonstrated truly cheap case with IMPELLA where complications happened, and obviously if you didn't have IMPELLA in place, each of these complications could be really high risk in terms of fatal outcome. Good demonstration. My one question, in addition to Dr. Davidson, if you put ProGlide pre-close and then you realize in the end of the case the patient will be with IMPELLA for next few days, what do you do with this ProGlide?
Oh, we actually, at the moment, we put them in betadine swabs and we cover them completely and thoroughly, plastered to the patient, and send the patient down. And we are able to use that, by the way, subsequently as well, and close it 24 to 48 hours later. I would actually emphasize the fact that we also need to learn how to, now that we have the wire available to us, the wire port available, especially in the smart assist. And by the way, if you have any thought of believing that the patient may be required to have the IMPELLA in for some time, then I would always use a smart assist now rather than just the CP alone, because that's what it's meant for. And that way you have a wire access all the time subsequently to be able to, even if the ProGlides, the pre-close was not done or was actually came out, you would still be able to close it with ProGlides afterwards, as long as you had the wire in. And that technique is also well described, and for everybody to learn that if you haven't pre-closed it, you can still close a 14 French hole subsequently with the two ProGlides. And by the way, de-escalation. Never de-escalate early, even in the CCU. Hemodynamics are extremely important to understand. I was going to demonstrate to you a patient where we had a tremendous success after 5 hours, and we took the IMPELLA out after 48 hours, believing that the patient was actually getting better just because his hemodynamics looked better, to the fact that as soon as we took the IMPELLA out, he deteriorated rapidly and died 24 hours later. So taking IMPELLA out is an art and science in itself. And when you do it gradually over a period of time with monitoring hemodynamics, understanding hemodynamics, and at the same time leaving a small dose of pressors, it helps myocardial recovery to the extent that it can be then taken out rather than too early. So I think that's an important aspect.
Do you routinely place a PA catheter, especially to decide on explant?
100%, yes. And we do all our cases with a PA catheter. Again, I want to emphasize Rustam, firstly, let me say hello to you. I just got to answer your questions, but great to see you. I'll be looking forward to seeing you here as well. But I think that's again for education. Peer captors are very important. Understanding peer pressures prior helps to understand peer saturations as well. And one of the criteria we use as a scoring system is a PA less than 55. It helps you to understand the right ventricular function adequately, understand PAPI as well. And finally, it helps you to decide volume depletion versus improvement in LV function as an important aspect of hemodynamics. So clearly would leave the PA catheter. By the way, in Smart Assist, if you just don't talk about the PA catheter, you talk about a thermodilation catheter, then it actually gives you a cardiac power output, which is the best indicator for long-term survival as well as explanting the impel. So I think that's another important aspect.
Anil sir.
Dr. Ashok, Anil here. Thank you very much for coming and giving your valuable comments and thoughts about IMPELLA. And I'm sure with your experience and your exposition, the crowd here is very happy to have learned from you. And we look forward to your CHIP CTO in New Delhi. Thank you, sir.
Look forward to having you, Anil, and you're an integral part of that. You, Deepak, and Raj Shekhar are a very integral part of the CHIP CTO.
Thank you.
Thank
Sir.
you.
So we'll conclude this session.